7-day dispute sprint. You've refused the box. Now we move fast. 7 days, 1 task per day. Keep your binder open and your scripts handy. This sprint is about freezing claims before they age in. Day 1, call 1-800 Medicare. Say, I'm reporting unsolicited DME tied to my Medicare number. I refused delivery, and I'm requesting a fraud tag and a temporary claim hold for this supplier. Read the supplier name, HCPCS code if you have it, tracking number, and ship date. Ask the rep to read back your case reference number. Write it down. Before you hang up, ask where to submit your photos. If they provide a fax or upload link, send the label and tracking screenshots today. Day 2, contact Senior Medicare Patrol. Open a case and email your evidence. Photos, your Medicare case number, supplier call reference, and your short statement. Unsolicited device, unopened, refused, no prior consent. Ask for guidance on local DME patterns and whether this supplier is active in your state. SMP's presence applies pressure. Put their case number in your binder. Day 3, if you're on Medicare Advantage, call your plan's member services. Ask them to flag the supplier, initiate an internal fraud review, and place a claims hold pending documentation. If you're on Original Medicare, call your DME MAC. Jurisdiction. Say, I'm requesting a review and hold on claims from supplier due to unsolicited DME and documented refusal. Get a reference ID. Note it. Ask how to submit your proof of non-delivery. Day 4, demand the paperwork from the source. Call the supplier and request, in writing, the prescribing provider's signed order, the telehealth or face-to-face notes, and proof of delivery with tracking and a signature. If they say it was left at door, that's not a signature. Note that if they mention an RA replacement, ask for documentation proving loss or irreparable damage and the incident date. No evidence, no RA. Email your request so there's a timestamp trail. Day 5, protect your identity footprint. File an FTC identity theft report at identitytheft.gov and select medical identity theft. Save the report number. Then submit a CMS fraud complaint using your Medicare case details, supplier name, and a concise timeline. This does 2 things. It documents intent, and it links your dispute across systems that investigators see. Day 6, close open doors. Call any pharmacies linked to mail orders and freeze all auto-ship programs you don't control. Revoke any telehealth consent forms you didn't sign with your primary care clinic. Tell your PCP's office to add a chart note. Tele-DME only via PCP referral. If you're on an Advantage plan, ask member services to disable auto authorization for DME without an in-network PCP referral. Day 7, follow up and confirm movement. Call Medicare back, reference your case, and ask, have any claims from supplier been received? Are they on hold? What's the next step? Do the same with SMP and your plan or DME MAC. If a claim already posted, request the Level 1 Redetermination form or portal link. Attach your refusal photos, the supplier's lack of proof of delivery, your SMP and FTC report numbers, and your PCP letter if you have it. Ask for a temporary authorization or a loaner device if a denial is blocking care right now. 2 Pro moves tighten the loop. First, send yourself an email with the subject Medicare Dispute Sprint, today's date, and paste your entire log, dates, names, reference numbers, and actions. That becomes a searchable record you can pull up on any call. Second, set calendar reminders for 14 and 30 days to recheck your Medicare summary notice and portal for any new activity from the supplier. Now, common snags. If a rep tells you they can't place a hold, ask them to document your report and escalate to their fraud or program integrity team. If a supplier offers a courtesy replacement, decline. Acceptance language can reset clocks. And if anyone claims you confirm details by phone, ask for the recording or transcript. Mills rarely have them. This sprint works because speed beats volume. You're freezing claims, building evidence, and forcing documentation when the paper is still fresh. By next week, you'll have holds in place, cases open, and the path cleared for appeals if needed. Lockdown, preventive settings, and scripts. Prevention is lighter than appeals, so let's harden your settings now. Start with your phone. Tape a short script next to it. I don't confirm Medicare information by phone. Remove me from your list. That's it. If they push, repeat it and hang up. Add one more line for persistence. Mail official notices only. You're creating a reflex, not a debate. Next, set call controls. On your cell, whitelist family, your PCP, your pharmacy, and your plan. Block unknown callers by default, and let voicemail filter the rest. Once a week, scan missed calls. Anything suspicious goes on your do not answer list. On landlines, enable your carrier's caller ID screening and require first-time callers to state their name. Scammers hate gates. Now lock down authorizations. If you're on Medicare Advantage, call Member Services and say, disable auto authorization for DME unless it's ordered by my in-network PCP. Ask them to note your file and send written confirmation. For original Medicare, call your primary DME suppliers and instruct no orders or refills without a signed PCP referral and my verbal confirmation on file. You want 2 locks, physician and you. Add a standing order to your medical record. At your next PCP visit, ask them to place this note on your chart. Tele-DME only via PCP referral. No third-party DME orders accepted without in-person or scheduled telehealth evaluation. Have them print the after-visit summary that shows the note. Take a photo and put it in your binder. When a supplier claims the doctor approved it, this note contradicts them. Tighten pharmacy profiles. Call mail order and local pharmacies. Turn off all auto-ship features except the meds you personally approve. Add a PIN to the account. If available, ask them to reject any new prescriber until you confirm. If they say they can't, tell them to annotate your profile with patient requires verbal authorization for any new prescriber or device. Email. Discipline helps too. Create a rule that shunts unknown health or benefits upgrade emails into a review folder. Scan weekly. Never click device claim links. If a message looks official, call the number on your plan card, not the email's number. Make one day your defense day. Once a year, schedule a 30-minute Medicare identity tune-up. Here's the checklist. Review the last 12 months of MSNs. Purge any unknown suppliers from your contacts. Verify your plan's DME settings and refresh your call blocks. If you've had 2 incidents in a year, ask Social Security for a replacement Medicare card number due to suspected medical identity theft. It's paperwork, but it resets the target. Create a quick access kit near your front door. A marker, tape, a refusal stamp or sticky, and a printed mini-script. Refused, unsolicited DME. When a box shows up, you don't hunt for tools, you execute. Beside the phone, keep your one-page call log. Date, time, who, reference number, outcome. Small systems beat big scams. Finally, rehearse. Do one dry run with a family member acting as a Medicare outreach caller. Practice your script and the hang up. It sounds silly until the real call hits and your hands shake a little. Muscle memory wins. Lockdown isn't about living paranoid. It's about pre-deciding. When your defaults are set, scams bounce. And when something slips through, your scripts and settings shorten the fight from months to minutes. When care is denied, appeal and override. If your claim gets denied, don't panic, shift into appeal mode. Start by getting the exact denial language. Ask the supplier or your plan for the remittance details and modifiers. You're often looking at a same or similar denial flagged by reason code 97 with Remark code N390, or you'll see KH/KR modifiers tied to capped rentals or replacement situations. Write those down. Codes tell you which rule blocked you. Now, lock in your timeline. You generally have 120 days to file a Level 1 redetermination with your DME MAC or with your Medicare Advantage plan through their internal process, which follows its own deadlines. Put day 0 on your calendar. You're going to build a clean, simple file that wins on paper. Here's your packet checklist. Your appeal form or letter. 1 page, clear ask. Please overturn this denial and approve device HCPCS code, if known due to medical necessity. Include your Medicare number, dates, and the denial codes. Proof you never received the same or similar item. Photos of refused boxes, tracking pages, refused unopened notes, and any carrier refusal scans. If it was an old shipment you never used, include a signed statement. Item never used, unsolicited with dates, and a label photo if you have it. Doctor letter. Ask your prescribing clinician for a brief letter on letterhead. It should say, your diagnosis, why the device is medically necessary now, prior conservative treatments tried, and a clear statement that no prior device of the same category was provided or used. Dates matter. Tie it to your current condition. Documentation trail. Medicare call reference numbers, SMP case number, and your FTC/CMS fraud report numbers if identity misuse is involved. This links your appeal to active program integrity flags. MSN screenshots, circle suspect E-codes that triggered same or similar. If a past code belongs to a supplier you didn't use, highlight it and add a sticky note. Unknown supplier, disputed. Before you submit, chase the supplier's paperwork. Email them and request the prescribing provider's signed order, the telehealth or face-to-face visit notes, and proof of delivery. If they claim it's a replacement, listen for the RA modifier. RA means replacement of a DME item. That's legitimate only if the original was lost, stolen, or irreparably damaged in a specific incident with documentation. Demand specifics. Incident date, what happened, and why replacement was necessary. No evidence, no valid RA. If they can't produce POD with signature or credible notes, say so in your appeal. Supplier failed to produce adequate proof of delivery and medical necessity. While your appeal is pending, protect your care. Ask your hospital DME or plan for a temporary loaner device. Use this script. This denial is under redetermination. Here's my case number. My doctor confirms medical necessity. I need a loaner to start treatment while we wait. Plans and facilities often have a path for this when therapy can't wait. 2 quick boosters strengthen your case. First, attach a copy of your PCP chart note that says tele-DME only via PCP referral, no third-party orders without evaluation. That contradicts any mill notes. Second, add a short timeline page. Bullet the dates. Injury or need, doctor visit, order written, denial received, documents requested, reports filed. Reviewers love clean timelines. Common pushbacks and counters. We show a prior device in window. Counter. Attached refusal proof and sworn statement. Supplier failed to show signed delivery. Prior line is disputed identity use. Replacement claimed under RA. Counter. No incident documentation provided. RA misuse to bypass same or similar. See attached request and supplier's non-response. Insufficient medical necessity. Counter. Doctor letter and visit notes attached. Conservative measures failed. Brace features meet current functional need. Submit your packet by the portal or certified mail. Keep copies in your binder. Set a 30-day reminder to follow up. And if you're on Advantage, track their internal deadlines. If they miss them, you may escalate to an independent review entity. Last piece, keep calling for the Mills notes. If the template is thin, 30 seconds, no exam, add that to your file. Bad paperwork loses to good paperwork. Your goal isn't a fight. It's a record that makes approval the obvious choice. The core fix, reclaim your Medicare identity. You've stopped the bleeding. Now we reset the identity that scammers touched so they can't reuse it. Think of this as changing the locks on your medical house. Start with your card. If you've had multiple bogus suppliers or repeat hits after refusals, request a replacement Medicare card and number due to suspected medical identity theft. Call 1-800-Medicare and say, "I need a new Medicare beneficiary identifier because my number's been used without consent." Ask what documents they need and where to provide your FTC report number and SMP case. When the new card arrives, store the old one and switch every provider to the new number deliberately, not all at once without a record. Next, clean your provider network. Make a list of every legitimate provider you actually use: PCP, specialists, hospital DME, pharmacy, and your Medicare Advantage plan if applicable. Call each office and update your new Medicare number. While you're on the line, add a chart note: tele-DME only via PCP referral. No DME orders without in-person or scheduled telehealth evaluation. Ask them to print or portal message an after-visit summary showing that note and file it in your binder. This closes a common mill door. Purge bogus suppliers from your record. Call the suppliers listed in your unknown provider list and state, "Remove me from your system. Do not ship or bill. I'm filing fraud reports." Ask them to send written confirmation they've closed your profile. If your plan shows them as in-network providers of record, ask your plan to block them from auto-authorization tied to your profile. Lock pharmacy profiles. Call mail order and local pharmacies and add 2 safeguards. Turn off all auto ship except meds you approve and add a verbal PIN for new prescribers or devices. Request a note: no new DME or supplies without patient verbal okay. If you use a caregiver, add them with authorization so they can enforce these rules. Replace telehealth consents. Any televisit you didn't schedule is a risk. Ask your PCP and regular specialists to refresh consent forms and list your approved telehealth platforms. Decline blanket consents that let third parties initiate device orders. If your plan offers remote monitoring or equipment programs, opt in only through your PCP's office, never a cold call. Centralize the paper. Build one binder. Front page is your master log. List case numbers from Medicare, SMP, your plan or DME MAC, plus your FTC and CMS complaints. Add a contact sheet with the fraud department numbers and your reference IDs. Behind that, keep tabs. MSNs with circles and notes, refusal folders, provider letters, and timelines for each dispute or appeal. One place, everything. It's how you win reviews quickly. Now, tell your circle. If you have a spouse, adult child, or caregiver helping, get HIPAA releases and plan representative authorizations on file so they can speak on your behalf. Share the phone scripts and the monthly MSN routine. 2 eyes on the account double the sentinel effect and cut billing runs short. Finally, reset your defaults. Keep your door kit ready. Keep your call script by the phone and set that monthly MSN reminder. A new number plus documented guardrails turns you from an easy mark into a hard stop. And once your records reflect those boundaries, mills tend to disappear because the risk of non-payment, micro-stories, and clawbacks 3 fast wins. Story A, the $3,200 stop in 7 days. Maria, 68, started seeing diabetic supplies on her MSN, test strips and lancets she didn't use. Total billed, over 3 months, $3,200. Why this mattered? She isn't diabetic, and repeat supply billing can run indefinitely and trigger same or similar flags for real devices later. What she did was simple. She refused the next surprise box at the door, wrote refused, unsolicited DME on the label, snapped photos of the shipping label and tracking, and asked the carrier for a refusal scan. Then she opened an SMP case and called 1-800-Medicare to tag the supplier and request a claim hold. She emailed photos and a 1-paragraph statement. Unsolicited device, unopened, refused. She also asked the supplier for the signed order, visit notes, and proof of delivery. They couldn't produce a signature or face-to-face documentation, just a template note. Payoff, claims reversed, $3,200 wiped, supplier blocked in her plan profile. The quick win clicked because she had clean refusal proof and reported fast, so the billing run died early. Story B, lab panel loop closed. Dennis, 74, noticed a repeating lab G-code every other month, genetic screening panels he'd never authorized. Why it mattered. Labs can add thousands and legitimize future DME with a paper trail. He applied the 3-line MSN audit. Who billed what code? When? The provider was in another state. Dates didn't match any appointments. He called the lab and requested the ordering provider's signed requisition and visit notes. They sent a generic televisit summary with 0 exam and no risk factors. Dennis circled the lines on his MSN, filed with SMP, and submitted a CMS fraud complaint with the requisition and note attached. He asked Medicare to place a program integrity hold and alerted his Advantage Plan's SIU team. Then he called his PCP and placed a chart note. No outside labs without PCP order. Payoff. The lab refunded, the ordering provider was sanctioned by the plan, and the repeating G-code vanished. The shortcut nobody teaches. Demand the requisition plus notes. Without a named ordering clinician and a real medical rationale, these panels are easy to unwind. Story C, scooter trial turned around. Eileen, 79, got pitched a free mobility evaluation. A week later, a scooter appeared on her MSN as a rental with a plan to convert to purchase. She never rode one. Why this mattered? Capped rentals stack month after month and can block future mobility devices. She moved fast. First, she asked the supplier for proof of delivery, the order with HCPCS code and modifiers, and the prescribing notes. They sent a drop-off photo at her porch, but no signature, no acceptance. She filed refusal evidence from her door kit on a second attempted delivery. Label photos, refused written on the box, and a carrier pickup scan. She also pressed on the RA angle. The supplier hinted it replaced a prior device. She wrote back, provide incident date and documentation of loss or irreparable damage to support RA. They had none. Eileen submitted a Level 1 redetermination within the 120-day window with her doctor's necessity letter, diagnosis, failed conservative care, and no prior scooter use, plus the porch photo mismatch and refusal scans. She asked her hospital DME for a loaner while the appeal processed. Payoff. Denial overturned, rentals reversed, and her legitimate mobility evaluation proceeded through her PCP with correct documentation. Now, the pattern across all three. Why these wins happened. Each person linked their MSN audit to immediate documentation and reporting. They didn't wait for annual summaries. They acted within days. What they used, the same toolkit, photos of labels, tracking pages, short sworn statements, SMP and Medicare case numbers, and targeted document requests that Mills struggled to answer. How they framed it, calm, repeatable scripts, unsolicited DME, refused unopened, no prior consent, send provider notes, order, and proof of delivery. And when RA or replacement language popped up, they demanded the incident proof that almost never exists. Common mistakes they avoided. They didn't open boxes just to look. Sealed plus refused kills charges. They didn't debate medical necessity on the phone. They requested documents and logged reference numbers. They didn't rely on a single report. They triangulated Medicare, SMP, plan, or DME MAC. The payoff you can expect when you follow this: faster reversals, shorter billing runs, and cleaner benefit windows.